Unfortunately, hasn't been a great change in the treatments available, but there is some exciting news on that, so I'll briefly mention that as well. So these are the latest UK thalassemia standards, were published in 2023 for adults and children and their management, and this is what it states around peri-operative management, in terms of that there should be sort of an assessment of risk, as already happens given that these patients are potentially high risk, the importance of considering all of their potential comorbidities. And I think the thing to highlight with the thalassemia patients is often these comorbidities can be hidden, and people often assume that these patients are very well, but they can have a lot of these issues sitting in the background. And then if they have a particular insult like an infection or a need for major surgery, then suddenly all of their comorbidities that they've sort of been hiding relatively well suddenly come to the fore. So it states, as I think we would already do in this trust, that they should have a review by an anaesthetist in a peri-operative assessment clinic, and that all of the cases for planned elective surgery should be discussed in the specialist hemoglobinopathy MDT, and discussed with our regional thalassemia sort of specialist centre, which is Birmingham, and they're happy to always discuss any specific cases, and we also have the option of referring to the national hematology MDT as well. And there is an expectation, because of the risks from splenectomy, that anyone who's having a consideration for splenectomy in the context of thalassemia, that should be approved by the National Hemoglobinopathy Panel prior to that being undertaken, due to the well-documented risks. And patients should be given information about the risks that they could potentially face during the surgery. So that's a summary of the standards. So briefly going back to the pathophysiology of thalassemia. So our alpha globin genes are located on chromosome 16, and we have two adult alpha globin genes, alpha 1 and alpha 2. Our beta globin genes, we have our two adult beta-like globin genes, beta and delta, and then we have our gamma globin genes as well, which are what's present in uterus, and a small amount continues into adult life. And as everyone knows, by about 6 months of age, most of our fetal hemoglobin has disappeared and has been replaced by the beta globin, leading to our adult hemoglobin. In the case of thalassemia, what happens is we get the imbalance of the hemoglobins. So in the case of beta thalassemia, we've obviously got the absence of beta globin chains that leads to the precipitation of the excess alpha globins within the red cell. And this leads to a range of changes and modification of the bone marrow environment via various signals in the bone marrow, including erythropoietin, GATA1, Fas ligand, and various other regulators. And this leads to increased differentiation of the red cells to try and compensate for this process. But due to this abnormal erythropoiesis, you then get apoptosis within the bone marrow, leading to dyserythropoiesis, but also in those cells that do make it into the periphery, you also get hemolysis as those cells are reduced. And like I say, this ineffective erythropoiesis has lots of different modifiers, such as epoetin, erythroferrone, TGF-beta, hepcidin. All of these different regulators correspond, and that leads to a range of sort of clinical sequelae, essentially. So you get anemia, which can lead to hypoxia and organ tissue ischemia. You get erythroid marrow expansion. This can lead to problems such as hepatosplenomegaly, osteoporosis, extramedullary hematopoiesis in bone, and endocrine complications from the iron overload, which is one of the main challenges and concerns that we would face. You also get hemolysis, which leads to depletion of nitric oxide, and this can causes lots of problems such as increased thrombotic tendency, leg ulcers, pulmonary hypertension, and obviously the other consequences of hemolysis, including gallstones. Alpha thalassemia is a slightly different story, but again, it's all to do with the imbalance between the alpha chains and the beta chains. But generally, the phenotype is less severe unless patients have no alpha globin genes. As people would appreciate, the alpha globin genes, when you have no alpha globin genes, you're unable to make any adult hemoglobin, and therefore there's a risk of hemoglobin BARTs, and that's generally felt to be still universally fatal. But there is sort of studies going on to look into treatment for that. Hemoglobin H is where you've lost one gene, and that generally is compatible with a mild hemolytic phenotype. But they do have problems such as extramedullary hematopoiesis, iron overload, endocrine problems, and can become anemic, particularly at times of stress. So we've got a range of diagnostic tests. We've got all of our old diagnostic tests, as you all know, our blood films. We've also got the opportunity of staining to look at fetal hemoglobin expression, and also, as you can see in picture C here, hemoglobin H expression. And also we've got our hemoglobin electrophoresis and high performance liquid chromatography. But in general now we're moving over to genetic testing to get a better idea of what's going on at the genetic level. And we generally routinely screen patients where we're considering thalassemia for their beta globin gene expression, their alpha globin gene expression, and their fetal hemoglobin gene, their gamma globin gene expression as well, because we know that patients can get a range of phenotypes, and often the genetics, the expected genetics, doesn't match the clinical phenotype of patients, and I'll come back to that shortly. So this again just shows you that overall pathophysiology of the thalassemia major with those excess alpha globin chains, and like I say, that peripheral membrane damage due to that hemoglobin H precipitation leading to hemolysis, and also that premature death of the erythroid precursors in the bone marrow. That obviously leads to the stimuli, like I've mentioned before, the increased erythropoietin expression and bone marrow expansion. Also via regulation of erythropoietin and hepcidin, you get that increased intestinal iron absorption, and also obviously if they're a thalassemia major patient, you get that increased insult of blood transfusion, further upregulating the iron absorption. So we know that obviously, as I've mentioned, that thalassemia is unfortunately, due to the complications of the disease, a multi-system disease, and leads to lots of different complications and issues, which we'll cover in turn shortly. So the other complicating factors, we do have a condition called thalassemia intermedia, as it used to be called, but it's now called non-transfusion dependent thalassemia. And these are patients who present later in life, sometimes in adulthood, but they can present in childhood classically as well, between 2 and 6 years of age, and that we sort of make the diagnosis on the basis of sort of delayed growth and development, and that's sort of how we would define it. But also in adulthood, like I say, sometimes we pick them up, particularly during pregnancy or other times of stress, such as if they've had a nasty infection or other sort of medical complications. And this is sort of due to the increased requirements of hematopoiesis at this time. And these patients, like I say, generally it's to do with the chain imbalance, which can be affected in a range of ways. So you can obviously get the standard beta thalassemia carrier, but if they, for example, have inherited additional alpha chains, so you can get mutations, whereas rather than having the standard 4 alpha chains on one of the chromosomes, they can potentially inherit either 3 or 4 alpha genes instead, and therefore this increases the production of alpha chains and therefore upsets the balance between the beta and the alpha globin chains, leading to a thalassemia intermedia or non-transfusion dependent thalassemia phenotype. Also, we know that the hemoglobin F is a big modifier of the phenotype. And so if patients inherit modifiers of their hemoglobin F production, which allows them to produce more hemoglobin F than would be expected from birth, then this can greatly modify the severity of the phenotype and make people, even who are homozygous for severe beta thalassemia mutations, still able to make relatively good amounts of hemoglobin. We also know that some patients, rather than having the classic beta 0 mutation, some patients have a beta plus mutation. So rather than making no beta globin change from that gene, they make some change, which allows them to make some hemoglobin A. There's also other hemoglobin variants which can combine with beta thalassemia genes to give a varying clinical phenotype, such as hemoglobin E and hemoglobin Lepore. And these are some of the most difficult ones, particularly when we're counselling young children parents about the birth of children, because these ones, it's quite difficult to predict how severe their phenotype will be. Some people with hemoglobin E beta thalassemia end up with a severe beta thalassemia major phenotype, need lifelong transfusion. Others, are very clinically well and need much less input. And hemoglobin H, we sort of classically count as a sort of non-transfusion dependent thalassemia state as well. So interestingly, the non-transfusion dependent thalassemic patients do have a different phenotype, and they do seem to get more problems with thrombosis. They tend to get more problems with leg ulcers and sort of problems with the kidneys, and this is probably and pulmonary hypertension, and this is probably as a result of them having more, an increased risk of hemolysis, and they're getting probably more hemolytic type issues and more depletion of nitric oxide in this perspective. Whereas your transfusion dependent thalassemias, it's the classic complications that everyone thinks of, the complications of hemochromatosis and endocrine dysfunction, liver issues and cardiac issues. The non-transfusion dependent thalassemics obviously can eventually get those complications if they are poorly monitored in terms of iron overload status. And this just shows you that spectrum of clinical phenotype in a different way. So we obviously have patients who never need transfusion or very seldom, all the way to obviously patients who are on regular transfusions up to every couple of weeks. So in terms of sort of the peri-operative optimization, then we need to look at all of these organs and issues in turn. So with our thalassemia major patients, we try to keep their hemoglobin trough as ideally around 100. And again, as we talked about with the sickle patients, we try to match their transfusions as closely as possible to ensure they avoid antibodies. The rate of production of antibodies and alloimmunization is significantly less than with sickle cell patients, but it is still a significant concern. There's lots of studies and investigations considering whether giving an extended phenotype of blood matching, so as well as matching for the Rh and the KEL antigens, looking at Duffy, KID, MN and S, but they haven't sort of conclusively shown with the blood resources we have available that this is really a viable option at the moment. But we are currently, and I think I did mention this briefly during the sickle cell talk, undertaking a genotyping program of patients' red cell antigens, so we get a better idea of what red cell antibody issues patients can develop to help with considering how we can better transfuse patients in the future. And there is a hope that using artificial intelligence and that in the future, perhaps the blood for patients may be matched specifically to the donors based on the red cell antigen expression to help with reducing the antibody production. And usually we say around elective surgery that we want to keep their hemoglobin 100 to 120 because there is evidence that having someone's hemoglobin too high can also be problematic. With the non-transfusion dependent thalassemic patients, one of the important reasons for assessing them is that they are particularly at thrombotic risk, as I've mentioned, and therefore it is sometimes useful to do a period of transfusion prior to any surgical procedure to try and reduce the number of nucleated red blood cells in their peripheral blood and help to sort of reduce that thrombotic risk. And there are several studies that have suggested that, and that's something that we would obviously advise and discuss in our specialist MDT. And there is clear evidence that that risk is highest in patients who've been splenectomized. Obviously, ideally, we want to identify the alloimmunization issues prior to procedures. We try to have all of our patients well labeled with blood bank so they can make sure that we know about thalassemics and we're giving them the appropriate blood products. But there's obviously patients that do slip through the net, so do always feel free to contact blood bank if you have concerns that we're not aware of a patient, in the region that we need to, because we do have access to the national SPICE system, which allows us to compare records with NHSBT and other trusts across the country. The rates of alloimmunization in thalassemia does vary quite a lot from study to study, but it's generally accepted that it's perhaps as much as 10 to 20% of patients. And it does seem that alloimmunization is generally higher and more common in people who start transfusion later. It's not completely clear why this is, but it seems that if children start their transfusion beyond the age of 1, that they can have a high risk of alloimmunization. It's thought maybe this is due to other complications that they're experiencing at the time, such as infection or other health issues, which has obviously triggered the need for transfusion, and whether this sort of heightens the immune response to the blood. But there is clear evidence that by doing the extended matching of the Rh and Kel antigens, we do reduce the rates of alloimmunization very effectively. And unfortunately, there's also evidence that once you have one alloantibody, the incidence of further alloantibodies over time is exponentially increased. So this is that genotyping program that I'm talking about, and this project which is looking at whether we can use genotype matching specifically to donors to try and give the best possible blood matches, because we recognize that the laboratory phenotype based blood matching is not foolproof. So going on to iron overload, there's obviously two mechanisms by which this happens. There's the adjustment of the body's own absorption of iron, particularly from the GI tract, and obviously potential transfusion. And the consequences of this is that once the transferrin receptors are overwhelmed by having too much iron in the body, this leads to the release of the toxic free iron and increased rate of deposition in tissues as ferritin and hemosiderin. And some tissues are somewhat protected from this, interestingly, such as skeletal muscle. But unfortunately, the cardiac muscle, endocrine tissue, and hepatocytes are very quick to absorb this non-transferrin bind iron, because it is particularly toxic and causes lots of complications, which I'll come back to. So obviously we know that the iron can deposit in the various tissues, as I've just mentioned, and lead to all of the associated complications. So one of the main complications we worry about, particularly around surgery, is the risk of cardiac iron. And the risk associated with that is various. There's a risk of sudden cardiac decompensation and sudden onset of heart failure. There's evidence for sudden onset of arrhythmias, particularly around this time. And therefore, for patients where we have significant concern of ongoing sort of iron overload, we would recommend continuous intravenous Desval, sort of 50 to 60 milligrams per kilogram, should be given throughout the peri-operative period, because this helps to neutralize the non-transferrin bound iron during the period of stress, to help to reduce the risk of sudden cardiac arrhythmias and cardiac decompensation. And again, ideally, if it's elective surgery, we'd also want to do everything we can peri-operatively to optimize the cardiac iron prior to surgery. Unfortunately, even once we do this, there is still an ongoing risk. We know even when someone's cardiac iron does normalize, they do still unfortunately have a higher risk of arrhythmias and cardiac decompensation, which I'll come back to shortly. So the ways we assess for cardiac iron has changed somewhat from historically. Obviously, historically, we used our ferritin and considered liver biopsy. But now we've tended to move away more to non-invasive tests. So we use MRI technology in the form of Peri-scan and cardiac T2 star. And these have great benefits of, like I say, being non-invasive. And the main technology we use for the liver monitoring is Peri-scan. And this is a software package that has been calibrated and is used around the country, and this allows the sort of results to be reproducible from trust to trust, so we can sort of compare the responses in iron more robustly. Obviously, it does have some downsides to it in that it doesn't give us an idea of the degree of fibrosis which is occurring in the marrow, but we do know that the risks of from fibrosis is most when the liver iron concentration is persistently above 15 milligrams per gram dry weight. So we try very aggressively to keep below this level, and it's felt that once we get the levels below 7 milligrams per gram, it's felt that there's unlikely to be significant adverse long-term risks from this. The cardiac T2 star is very helpful, because it, as well as giving us the measure of the iron in the heart, it also helps us to assess the cardiac function more reproducibly, because as everyone understands, the echocardiogram is quite user dependent, and so you can miss subtle variation. And the other problem with the echocardiogram is we obviously know patients with thalassaemia, like sickle patients, are hyperdynamic, so we expect their ejection fraction to be supranormal. So once it is already showing that it's dropped to back to normal levels, that does suggest some degree of cardiac impairment. So this shows this is quite historic data, but it is quite still useful to just give us an idea of the effectiveness of iron chelation. So historically, death at 20 years was 5% in patients with thalassaemia in 1970, and the risk of hypogonadism, diabetes, hypothyroidism, was very significant. And you can see that has improved significantly following the start of iron chelation with desferrioxamine. But still significant rates at that time of hypogonadism, hypothyroidism, and diabetes. So we've got 3 iron chelators that we classically use now. We try to avoid desferrioxamine as much as possible because it's obviously needs parenteral administration. So we try to use the oral agents, deferrosirox and deferroprone, and they have a range of toxicities and monitoring requirements. So as I mentioned, with the cardiac complications, there's a risk of acute heart failure, arrhythmias, particularly VT and atrial fibrillation are very common. Historically, there used to be quite a high rate of myocarditis and pericarditis, but the rates of this now are not well understood in the context of sort of better iron chelation and control of cardiac iron. Pulmonary hypertension, as I mentioned, does seem to be particularly high risk in the non-transfusion dependent patients. So this just tells you, shows you a little graph of, as the cardiac iron increases, the risk of developing heart failure over time. So you can see here, once the cardiac T2 star is less than 10 milliseconds, that sort of suggests a significant increase in risk of heart failure over the following 12 months, and that risk increases as the T2 star drops below 10. So by the time you get to less than 6 milliseconds, the risk of heart failure is up to 50% in the next 12 months. So this just talks you through that pathophysiology of pulmonary hypertension and that endothelial dysfunction and vasoconstriction leading to the pulmonary hypertension. So next is endocrine complications. So we know we get a range of endocrine complications, including thyroid problems, problems with the parathyroid hormone. So we would suggest that it's important that those are screened for prior to surgery where possible. And in the case of emergency surgery, obviously having a low threshold for administering hydrocortisone. And also just being aware that diabetes can also go undiagnosed, and therefore we recommend doing regular oral glucose tolerance testing, because HbA1c, obviously, as you know, is not a reliable test in this context. Also, MRI can be useful in terms of identifying iron overload in these different endocrine tissues, and there is work about whether we can do similar testing to Feriscan, to confirm the level of damage, because there is studies that show that the MRI findings do correlate very closely with the likelihood of pituitary failure. So this just is quite an old study, but shows you in, I think, children from Cyprus, the rate of, it's relatively old, so hopefully the data is better now, but you can see the rates of endocrine complications are, very significant. Infectious complications is also something that's very important to be aware of. So we know that patients with thalassaemia, because of the excess iron in their body, are particularly at risk of things such as Yersinia, Klebsiella, E. coli, strep pneumonia, and Pseudomonas. And it's felt that this is probably due to the ineffective erythropoiesis and hemolysis, resulting in the monocytes, macrophages, having to spend a lot of time dealing with this rather than focusing on fighting the infection, in addition to the presence of the excess iron, which is obviously very attractive to the bacteria. So Yersinia enterocolitica is one that's particularly worth being aware of, because it's very common in patients on desferrioxamine. So if patients on desferrioxamine present with fever, abdominal pain, enterocolitis, it can look very like appendicitis, and obviously that should be excluded, but it can also be that it's Yersinia enterocolitica, and it does usually respond relatively well to stopping the desferrioxamine and starting broad spectrum antibiotics. Klebsiella is another one that's unfortunately quite common, and I've heard from colleagues that they can get very rampant Klebsiella infections. I've not personally seen this, but it is well recognised. So as I mentioned earlier, splenectomy is generally felt to ideally be best to be avoided now, if possible, due to the long-term risks of sepsis, thrombosis, and pulmonary hypertension, as well as it probably enhancing iron overload in some patient circumstances. So you can see the data in the 1960s was to offer transfusion-dependent thalassemics. Over half were having a splenectomy, whereas by the 1990s it was around 7%, and now it's probably even reduced from that further now. So we do still consider splenectomy sometimes for patients, particularly if they have a very high transfusion requirement. But like I say, this requires national MDT approval. Thrombotic risk is something else which is very important, and the importance of thromboprophylaxis should always be used. Some patients, if they've got particularly other strong risk factors, might be on long-term anticoagulation, particularly if they have a portacath in situ. And the incident rates vary between studies, and there hasn't been sort of good studies showing the exact incidence, but they can get a range of manifestations, particularly as well as being the standard DVT-PE, but also increased rate of arterial events and unusual sites such as portal vein, cerebral vein. And we know that some risk factors increase this risk further, such as obviously age, splenectomy, as I've mentioned, but also chronic anemia, iron overload is another risk factor. So there is a risk scoring system that's been developed by Tahir and colleagues, and they've looked at this as a risk score that can be used to help to predict the risk of thalassemia patients. And obviously then you can try to adjust these modifiers in terms of improving hemoglobin and reducing ferritin level, considering transfusion to try and help to reduce this and modify this risk. I'm not going to spend any time on the airway because I know that you're the experts in this, but obviously we know that thalassemia patients do get orofacial malformations, which can lead to problems and complications with airway management. And again, the extramedullary hematopoiesis can obviously occur in the spine and lead to problems with neuroaxial anesthesia. Obviously, pregnancy is one of the key times when this can occur, and I think all of the management and advice I've talked about in this talk applies to that too. But there is a recent BSH guideline around pregnancy in thalassemia, and we also have a trust guideline. So sorry, it's been a bit of a whistle-stop tour,